Welcome, and thank you for joining us today for the pre-application webinar, Improving the Reach and Quality of Cancer Care in Rural Populations. My name is Jennifer, and I will be your WebEx host for today's webinar. Before I turn our presentation over to Sally Weaver, I'd like to review a few housekeeping items. All attendees have been muted upon entry and will remain muted for the duration of the webinar. Please submit your questions throughout the presentation using the Q&A or chat panel and select all panelists from the drop-down. We will ask them on your behalf during the Q&A portion of the webinar. If you need closed captioning, please click the link that will appear in the chat box momentarily. Questions about specific aims or those specific to your application will not be addressed during the webinar. Please note this webinar is being recorded, and now I'd like to turn it over to Sally Weaver.
Thank you so much, Jennifer. And hello, everyone. Thank you so much for taking time to join the call today, and thanks to all of you who submitted your questions in advance. I'm excited to be here today on behalf of Shobha Srinivasan, who is the Health Disparities Research Coordinator for the Division of Cancer Control and Population Sciences and the scientific contact for this RFA. Before we get started today, I'd also just like to quickly thank Jennifer Schaefer and Crystal Reed for their assistance in setting up today's webinar. And I'd also like to mention that I'm very excited to be joined by my colleague, Dr. Brian Kim, today. Dr. Kim is a fellow program director here in the Healthcare Delivery Research Program, and he'll be kindly assisting me with the Q&A portion of today's webinar. So with that, I'll start with just a brief roadmap for the rest of today's webinar. I'll start with just a very brief bit of background and then walk through a summary of the RFA details, including the goal and scope of the RFA, application dates and resources. And then last but not least, we've reserved some time at the end for your general questions. I do want to note that we cannot answer questions about your project-specific aims or specific project details on the call today, but both Shobha and myself are more than happy to speak with you one-on-one if you have specific questions related to your project. We've been sure to include our email addresses throughout today's webinar, and I definitely will encourage you throughout the webinar today to reach out to us by email if you have questions related to your project. I also do want to go ahead and note that today's webinar slides, a list of frequently asked questions, and a recording will be posted on the web for you in the next couple of weeks. So with that, let's go ahead and move on and talk a little bit about the backgrounds and impetus for this RFA. So, of course, NCI and our division have a long history of supporting research focused on understanding and reducing health disparities. But our focus on rural cancer control research and rural cancer care delivery in particular really sharpened based on data showing that cancer has persistently taken a bigger toll in rural America. These are data from the SEER Cancer Registry from an analysis that was done by my colleague Kelly Blake, showing that the overall death rate from cancer is about 10% higher in rural communities compared to urban communities. That's that top green bar on the right-hand side of your screen. And then when you break these data down by cancer site, you can see that this is driven in part by high death rates from cancers like lung, head and neck cancers, cervical, and colorectal cancers there on the left. Looking at these data over time also provides a compelling snapshot, and these, of course, are data from our colleagues at the CDC that show cancer mortality rates from 2006 to 2015 for all cancers combined on the left, and then for 4 specific cancer sites, lung, colorectal, breast, and cervical on the right. Rural counties are the solid lines, and of course, metro counties are the dashed lines. So although death rates from cancer are decreasing in both rural and urban areas, deaths are decreasing much more slowly in these rural areas, and that's just further compounding the disproportionate effect of cancer on rural Americans. So despite some pockets of success, these data definitely are demonstrating that the rural-urban disparities in cancer are persistent, and it's data like these that have really sharpened our division's focus on cancer among rural populations and really emphasized to us the need for sustained support for rural cancer control and care delivery research. Given that, I also want to just underscore that the RFA we're talking about today is just one tool in the broader collection of activities that the Division of Cancer Control and Population Sciences has been supporting to stimulate research on rural populations. So with that, let's go ahead and take a closer look at the details of this RFA. So the goal of this RFA is to stimulate research that improves the quality of cancer care in rural areas among low-income or underserved populations And to this end, the RFA allows for two types of R01 clinical trial required applications. You can propose either one of these types of applications, either an application focusing on observational research that includes pilot testing to understand or address predictors of cancer care and treatment and outcomes in rural, low-income, or underserved populations, or you can put forward an intervention research application that is focused on addressing factors that are known to contribute to disparities in care quality and outcomes among these populations. I think the take-home message here is that the focus is really on research that informs efforts to develop and implement strategies for delivering high-quality, accessible cancer care to rural, low-income populations. So that said, we're encouraging studies to develop and implement interventions in community-based clinical settings. Studies are also encouraged to address quality of care indicators, cancer care delivery challenges in rural populations, and other barriers. So just to reiterate, this RFA does not focus on epidemiological studies documenting rural-urban disparities. It does not focus on studies primarily doing rural-urban comparisons, and it does not focus on primary prevention research in healthy populations. We have funding mechanisms that support that type of research, but just that's not a focus of this particular RFA. The focus is really on research about strategies to improve the reach and quality of cancer care in these rural low-income populations. So let's dive a little bit deeper into observational studies. So observational studies with pilot testing, of course, should focus on understanding and addressing the predictive or mediating role of social determinants of health, barriers to care and treatments. These applications must include at least one aim, that is pilot testing and intervention, and budgets for these applications are limited to $400,000 in direct costs per year. The maximum project period for observational studies with pilot testing is 5 years. And I'll also just point out that the entire RFA is not focused on issues related to recruitment and retention of participants to clinical trials. Now, the second type of application that you can put forward, intervention studies, these should really address quality of care related to cancer diagnosis, treatment, or survivorship by targeting these predictive or mediating factors. Of course, we do recognize that most of the existing cancer control interventions are not ready, perhaps, for direct implementation and dissemination in low-income rural areas. So applications can seek to develop, adapt, implement, and test these types of interventions. Now, budgets for these types of applications are limited to less than $500,000 in direct costs in any year. Again, the maximum project period for these applications is also 5 years. And again, projects should not focus on recruitment and retention to clinical trials. So regardless of which type of application you choose to develop, this RFA does have a few requirements. First, and very importantly, it requires that applicants define the rural population for the proposed study based on the 2013 Rural Urban Continuum Codes, or the RUCC codes. And we really encourage applicants to focus on populations with RUCC codes from 4 to 9. Now, I can't underscore this enough. This is really important. Applications that do not include a description of the target population using these RUCC codes will be considered non-responsive and actually won't even get reviewed. So please make sure that is in your application. The second requirement is that applicants must justify how the proposed study addresses a rural population that's also primarily low income. I think the critical takeaway here is you must be sure to do both of these things. It should be really, really clear to reviewers what RUCC code your target population falls into, and that you're also addressing a rural population that is primarily low income. We have received a lot of questions from folks wondering if they could use other definitions to define the rurality of your target population. I think the short answer is you can use the RUCC code plus another different type of code or parameter to define rurality, but at the very least, it must be sure that the RUCC code is clearly discussed in your application. If you're not familiar with the 2013 RUCC codes or RUC codes, I provided a link on this slide where you can find these codes for all U.S. counties. And again, the RFA is really focused on populations in that non-metro RUCC codes, so codes 4 through 9, and programmatically will prioritize studies that are focused on some of the most rural populations. Those studies focus on populations with root codes of 7, 8, and 9. Applications can cover quite a broad range of activities that contribute to cancer care delivery and treatment challenges in rural populations. These next 2 slides will just give you a couple of examples to help inform your thinking. So studies focused on barriers to accessing health services, so things like financial hardship from being underinsured or uninsured, physician shortage, lack of transportation, place and built environment issues, prejudice and discrimination. Additionally, studies focused on evaluation of natural experiments, programs, and policies to improve care and access that may interact with the implementation of an intervention. Note for this, the focus here is really on multi-level studies that are accounting for the effects of a natural experiment in addition to an investigator-driven intervention. So studies examining natural experiments that actually don't look at their interaction with an investigator-driven intervention are not a focus of this RFA. Other activities include studies looking at the role of social determinants of health, studies looking at the limitations in information technology that might limit access to things like patient portals, telehealth, or other strategies to improve patient-provider communication and care in rural communities. Also studies looking at IT-enabled team-based care delivery models that could improve delivery of guideline concordant care, as well as interventions designed to improve primary specialty collaborative care to help enhance the dissemination of state-of-the-art cancer care and follow-up. Again, this is in no way an exhaustive list, but it just provides a few example research areas of interest. In terms of collaboration, I mean, we certainly recognize that a wealth of rural health expertise exists outside of the traditional cancer research enterprise. So the RFA does clearly promote collaboration among researchers from the cancer control community and others. So demographers, geographers, transportation researchers, economists, psychologists, implementation scientists, sociologists who have experience working on some of these really diverse factors that might be potentially relevant to rural cancer care and delivery. It's also equally important that these projects are developed and designed with relevant community stakeholders and rural healthcare delivery partners. So we are really encouraging applicants to collaborate with relevant community stakeholders and rural healthcare delivery partners, as well as other organizations and programs that might have experience or infrastructure that are really designed to address health or social problems in rural communities. So, for example, partnerships with community-affiliated clinics or hospitals, state or county offices of rural health, departments of health, education, or human services, or other community organizations, as well as engagement of community advisors are all strongly encouraged. There are several types of projects that will be viewed as non-responsive to this RFA, meaning that applications that propose non-responsive projects will not be reviewed. So this includes applications that fail to use the RUCC code somewhere in their application to define the rural population of interest, applications focused on issues related to recruitment and retention of participants to clinical trials, applications focused only on primary prevention interventions among healthy populations or screening without adequate attention to abnormal screening follow-up, as well as studies of natural experiments, as I mentioned, without an investigator-initiated intervention. So, as a friendly reminder, all applications submitted to this RFA are required to include a clinical trial. So that means including the PHS, human subjects, and clinical trials information form as part of your application package. Many folks on the line are probably familiar with this form, but if you're not, there is a link to detailed information about this form and a list of some of the information you must include listed here on this slide. There's also just a ton of resources available to you to help clarify our requirements for clinical trial applications, and you can find all of that information on the website listed here on slide 19. So All applications for this RFA must, of course, follow the page limits and other requirements for R01 clinical trial applications. So that means that you have, of course, 1 page for your specific aims, 12 pages for your research strategy, and up to 5 pages max for each bio sketch. I also really strongly encourage you to reach out to Shobha or myself when you have your 1-page specific aims developed. You can send them directly to Shobha by email. Her address is here on the screen, and we are more than happy to talk with you about them. Don't worry, it doesn't have to be in final or perfect form. We're glad to talk with you at any stage once you have that 1-pager kind of drafted. All applications will be reviewed by a special emphasis panel convened by NCI. Of course, all applications will receive an overall impact score, and standard scored review criteria will be applied. So basically, reviewers will be scoring each area on the left of this slide individually. So significance, investigators, innovation, approach, environment, and they'll consider all of these in crafting their overall impact score. Additional review criteria listed on the top right of this slide are not scored individually, but they are considered as part of the overall impact score. So this includes things like the study timeline, which is required for applications for this RFA because clinical trials are required for all applications. Things related to protection of human subjects, as well as plans to address inclusion or exclusion of individuals on the basis of sex and gender, race, ethnicity, as well as the inclusion or exclusion of individuals of all ages, including children and older adults. So for these criteria, reviewers will basically be looking to see if these aspects of the application are well justified in terms of the scientific goals and research strategy proposed. And last but not least, reviewers will also be asked to comment on whether resource sharing plans or the rationale for not sharing resources are reasonable. And this is simply an additional review consideration that's actually not considered in the overall impact score. And one thing I just want to mention and remind you is that for this RFA, all applications must include a data sharing plan. So next we'll go over just a few important dates. First, letters of intent, and the earliest submission date is December 15th, 2019. While LOIs, letters of intent, are not required in order to submit a full application, I will say I would strongly encourage you to consider submitting a letter of intent, at least with the title of your project, key partners, and things like that. That information is so important for helping us plan and to help the scientific review officer to prepare for the special emphasis panel of reviewers. Again, submission of a letter of intent is not binding, and the letter is actually not part of the application review in any way, but it can be very helpful to us. While we do strongly encourage you to submit that, of course, we also welcome your application if you choose not to submit the letter of intent. Full applications are due January 15th, 2020 by 5 p.m. at the latest. Definitely, I will strongly encourage you to submit before this date. Then we're anticipating that scientific review will occur sometime in May or June 2020, and we hope to fund by December 2020. Overall, of course, just be sure to start the application process early and read the RFA very, very carefully, and reach out to Shobha and I at any time if you have questions. So as I mentioned, today's webinar will be posted on our website, and here is Shobha's email address one more time. Here are just a couple additional resources that might be helpful. We held a workshop with the National Academy of Sciences, Engineering, and Medicine back in 2018 that was focused on improving health research in small populations. The publication on that, of course, is out, and it does have some relevance for rural cancer control research that's being solicited here in this RFA. We also have a very nice rural cancer control website where you can find out more information about this National Academies meeting. You can take a look at the broader portfolio of rural research that we're supporting, find other funding opportunities aside from this RFA that are focused on rural populations, and as well, you can also find some other publications that might be relevant to your work there on that website. So with that, I do want to thank you again for taking time to join the webinar, and we'll start to open things up for your questions. Before I turn things over to Brian, though, I'll just go over a few ground rules for questions. would ask you to please type your questions into the Q&A section on the WebEx website. And just a friendly reminder that we can't answer questions about your specific proposal or ideas today, but you can certainly send those to Shobha and I by email. And I'd also just like to remind folks, this is a public webinar, so just be mindful of sharing any unpublished data or other information that you wouldn't want to have discussed publicly. So with that, I'll turn things over to my colleague, Dr. Brian Kim. Brian?
Great. Thanks, Sally, for the great presentation. So the first question is, if a letter of intent is submitted, would we be afforded feedback regarding the LOI and our planned proposal and study design?
So that's a great question. No, written feedback will not be provided for letters of intent. Of course, as I mentioned throughout the day, you're welcome to submit a one-page specific aims to Shobha and I via email, and we can certainly discuss that via phone, but we will not be providing written feedback for letters of intent.
When we submit the final grant proposal and study design on or before the January 15th deadline, should the study design protocol be IRB approval ready?
Oh, that's another good question. So, of course, an IRB has to approve your protocol if you're involving human subjects, but actual IRB approval is not required any longer prior to review of your application. What will basically happen is if your priority score is determined to be sufficiently favorable, NCI staff, such as myself or Shobha, would reach out to you requesting that you supply notification of IRB approval for your protocol. That's not a guarantee of funding, but it just indicates that the application is under further consideration. So basically, you don't have to submit IRB approval prior to review, but if you're in that kind of fundable consideration range, you will be asked to submit that information.
Great. As far as study design is concerned, is there a particular study design that is encouraged or would have seriously considered for? In other words, a single arm or randomized study design?
So, no, there's no preference as far as study design. The only thing I guess I'll say is your study design clearly should be driven by your research questions and just really well justified in your application.
With regard to eligibility under this FOA, what defines rural area?
Okay. So again, the RFA requires that applicants define their rural population for the proposed study using the 2013 Rural-Urban Continuum Code. So basically, you need to make sure that you're clearly justifying that you're working with a population that's in a non-metro area as defined by the RUCC and that they are primarily low income or underserved. Now, I think this question gets at, is related to some of the other questions we've had come in ahead of time. One thing I do want to clarify is that the population of study must be rural and low income, but applicants themselves are not required to be located in a rural area.
Within the RFA, it states that you're looking for interventions designed to improve primary specialty collaborative care to enhance dissemination of state-of-the-art cancer care and follow-up. Would supportive care interventions be seen as responsive to this?
Yeah, great question. Definitely. Studies of supportive care, symptom management in rural, low-income populations would definitely be responsive.
This user would like to use the NCI Community Oncology Research Program, NCORP, network to conduct a study in response to this RFA. Is there anything special I need to do if I want to study within the NCORP?
Yes. Oh, I'm so glad somebody asked this question. There are a couple of additional steps that will need to take place if you're going to plan to use the NCI Community Oncology Research Program. If you're planning to interact with NCORP research bases or clinical sites in any way, you must speak with NCI NCORP staff before submitting your application proposing a study in NCORP. So to that end, if you're thinking about NCORP, if you're for sure that you want to use NCORP, please send an email to Shobha and I as soon as possible to let them know let us know that you're planning to conduct this type of study, and we'll put you in contact with the NCORP staff here. We'll have a group conversation about that and help you move forward.
Can you direct us to resources that help address the translatability of projects carried out within rural populations? For example, demographics of qualifying RUCC areas in my region tend to be homogeneous, such as more than 90% Caucasian.
So that's a good question. I'm not sure I have enough information to answer that question today, but I would definitely encourage the person who asked that question to reach out to Shobha and I to talk a little bit further about that.
Would genetic cancer risk screening, counseling, and testing in rural areas be considered in this RFA?
So that's another good question. So the focus here is really on the part of the continuum during screening and diagnosis and after that, so treatment and survivorship as well. So if that genetic screening work is related to the diagnosis and treatment planning process, then that potentially could be responsive. If the focus is on genetic screening in healthy populations, then that would not be responsive to this RFA.
Is there any interest in conducting RCTs of behavioral interventions with this group?
Oh, that's another good question. So again, I think this kind of falls in line with the previous question. So, I could see a responsive study potentially looking at public health activities like ongoing surveillance or physical activity promotion during treatment and survivorship. But again, the focus is not necessarily of this particular RFA on behavioral intervention in yet to be diagnosed or screened populations. We have other RFAs, several prevention-oriented RFAs that we certainly would encourage you to apply to. Even if you're focused on rural low-income populations, you can still certainly apply to those other funding opportunities that we have on primary prevention.
I guess this is a leading question. Would cancer prevention interventions such as CRC screening be okay?
So, no, these are great questions. So, I think the important thing to take away, as I mentioned, is that studies that focus on screening without adequate attention to follow-up to abnormal screening would not be considered responsive. So if your endpoint is just were they screened or not, that would not be responsive. That's not the type of application that this RFA is really focused on. If you're going further than that and looking at how that progresses then into abnormal, follow-up to abnormal and treatment planning and things of that nature, then potentially that could be responsive.
Does the direct cost limit include consortium FNA, or is consortium FNA on top of the direct cost limit?
Good question. So the direct cost limit refers exactly to just that, just direct cost. So your FNA consortium, you can use that FNA consortium form to calculate those out. So those are not included in the direct cost cap.
Can the PI email the letter of intent, or does it have to be routed through the Office of Sponsorship?
Oh, that's a good question. It would be great to have it routed through the Office of Research Sponsorship, but the PI can also submit the letter of intent directly to Shobha and I. That's completely fine.
What urban-rural continuum is required? 4 to 9?
Okay. So we are focused on studies that look at populations that are in the RUC codes, the 2013 RUC codes, specifically on populations in RUC codes 4 through 9. So actually, if we go back, let me pull up the right slide here. I apologize. Here we go. So in particular, we're interested in applications that focus on populations in RUC code 4 through 9. We'll also give special consideration to applications that are focused on those really highly rural populations, so those counties and areas with RUC codes of 7, 8, and 9, but anything from 4 to 9 is counted in the definition of rural that we're using for this particular RFA.
If we submit it to the original RFA, are we allowed to resubmit to this reissued RFA as a resubmission?
Great question. I'm glad somebody asked that. So the short answer is no. Even if you submitted to the previous version of this RFA, if you're submitting to the current version, it needs to be treated and it needs to look exactly like a brand new application. So unlike a resubmission, you will not be able to write a one-page cover that explains your previous response to previous reviews and things of that nature. You can certainly take those comments into consideration, but the package needs to be formatted and looks just like a brand new application. You cannot refer to the facts that you submitted previously. You cannot refer to previous reviewer comments. Anything along those lines is not allowed.
If you're planning to do a multi-center trial through an NCI NCORP research base, should every individual site fulfill the RUCC criteria? Should they all fulfill the same RUCC criteria? Is there a way to link NCORP sites with RUCC criteria?
So that's a good question, and that is something that Kate Castro and our team who leads NCORP, I think it would be great to have a conversation with them about. So whoever submitted that question, I would be glad. Please reach out to Shova and I via email, and we would be glad to have a conversation with the NCORP team to talk about that.
Great. Are there any lessons learned from the 2018 issue of this RFA?
That's a great question. I mean, I think the lessons that we learned certainly are reflected, I think, in some of the very specific examples of non-responsive studies that we received in the previous iteration. So I would just emphasize, make sure that it's very clear to reviewers and outside readers that you are focused on a rural population that's defined by the RUCC code that is low income and or underserved. Again, applications that are focused on recruitment and retention to clinical trials, that's another thing we just want to be clear about, and some of these other issues here. So I think those are certainly some lessons learned. The other lesson learned that I think just in general, as we've been really reinvigorating the rural portfolio and the other rural initiatives, we have a large number of supplements that we've also given out in this area, as well as other studies that we funded outside of the rural RFA. And I think one takeaway is that, there are a lot of state, county, and local entities that are working to improve rural health, and so reaching out and working really closely with those groups like your state or county Office of Rural Health is so important. They have the connections and the relationships. They have the experience and expertise, and there's a lot to learn to do this research from those types of groups. So I would definitely encourage you to, if you haven't done so already, meet with your state Office of Rural Health, meet with your departments of health and the rural liaisons within your departments of health. They can be incredible resources.
I think this is a leading question, but would you be able to provide examples of poverty or low income that work, such as shortage areas?
Okay, good question. So I will direct you to slide number 12. So we don't have a hard and fast definition for low income for this RFA, but these are, using the ASPE poverty guidelines as well as the USDA ERS definitions are two potential options. I think the key point here is that there are rural communities that are very well resourced, and that's not necessarily the population that we're focusing on in this RFA. So there just needs to be some justification that you're targeting low income or underserved population, and then it will be up to reviewers to consider how well you've made that justification.
If your study population is rural, from the codes 4 to 9, RUCC 4 to 9, but a healthcare system partner who serves these rural patients is in an urban area, is that okay?
So that could potentially be responsive. I think, again, it's up to you and your study team to really write a compelling justification and make the case that the population being served and targeted through this research will be low-income rural residents.
Would a U.S. territory in the Pacific qualify as RUCC, or are you looking for mainland studies only?
Oh, that's an interesting question. I mean, anything that qualifies, so certainly that it sounds like that could qualify. Shova and I'd be happy to have a more in-depth conversation about that. But so long as there is an RUCC code that's clearly affiliated, or if there is other justification like tribal or reservation land that would fit a clearly rural definition, then that works as well.
Would applications that focus on survivorship and quality of life be considered?
They certainly could be. And so again, I think the focus is really just on justifying that you'll be researching that in this particular population.
Is it possible to request a budget in excess of the stated caps of 400,000 K and less than 500,000?
No. Since this is an RFA, you cannot put in a request for anything over these budget caps.
The last question. For this RFA cycle, how many awards will be granted for this specific RFA?
So depending on, of course, receiving funds and meritorious applications, we're intending to fund anywhere from 4 to 6 awards, and that corresponds to about $3 million for fiscal year 2021. Future year amounts will just depend on annual appropriations.
Great. Thank you for all the questions answered. I'll turn it back to Jennifer.
Great. Thank you, everyone, for all the questions you've submitted, and for Dr. Weaver for just explaining and doing a great presentation. Again, if you had any questions that weren't answered today, if they were specific to your application or your aims, or if you don't feel like the answer kind of answered your specific question, please feel free to reach out to Sally or Shobha to address your questions. We're pulling up their information right now on the slide. As Sally mentioned, a recording will be posted along with the slides and a frequently asked questions document to the website within the next few weeks. We'll be sending out an email once those resources are available. Again, if you have questions, please feel free to reach out to Sally and Shobha. Thank you again for your participation.